So today in Cairo, my talk was about BRCA testing in breast and ovarian cancer. It was part of a large session on BRCA mutated patients with the aspect of surgery and treatment. So the facts that I wanted to point in my presentation were several different aspects of what is the test that we are running. So I explained the NGS, I explained the HRD test, homologous recombination defect test. I explained the difference. And then I was going into the strategy, because in fact today we have, historically we were looking at BRCA genes for familial history. So it was something that we were looking at for ovarian cancer, high-grade ovarian cancer, or for mainly triple-negative breast cancer, but also in young women, or if it was a family history. So this was working, but it was a very long process, and it was disconnected from treatment. But now, knowing the status of BRCA1 or BRCA2 genes has also a theranostic implication for treatment for platinum salts and also for PARP inhibitors. So I explained the strategy of testing for ovarian cancer, where we can start testing the patient at the diagnosis, in parallel in the tumor and germinal, or at the recurrence. In ovarian cancer, it's very important to have also the BRCA testing in the tumor, because we can have 7 to 14% of extra patients benefiting from treatment. For breast cancer, it's different. It's a new kid on the block. We were also looking at BRCA tests for familial, but not for theranostic. So it's very different, because there are much more breast cancer than cancers than ovarian cancers. And usually we think about BRCA testing for the triple-negative breast cancer, but not for the other ones. So I really insisted in my talk about thinking about BRCA testing even without a family history of breast cancer for the metastatic patients, and especially for the luminal breast cancer, because I'm sure that for the triple negative everyone is going to think about BRCA testing, but not for the hormone receptor positive, and those patients are usually BRCA2 by the way. In my experience, we test all the ovarian cancer. We test them at diagnosis in my hospital, but sometimes we have patients arriving with metastatic. So we try to have short duration time, and we start by testing the tumor, and then if it's positive, we refer to the oncogeneticist. For breast cancer, we have started to do that like 1 year ago, to screen patients for new drugs. So we are starting to do that, and it's a lot of workflow. So it has required to have more technician doing that, because it's a lot of patients to do that. But we try to be systematic. I attend this congress every year since 5 or 6 years, I don't remember, and I'm always delighted to see how many people are attending, the very accurate question they ask, and I'm really very happy to participate to this congress in Cairo.